Sanbonan colleagues, I think now we can start our day. For those Labetago, they will find us on the way. Yes, so I think we can continue. So I think it will help us to continue and be able to finish maybe on time today. What I'm noticing is that our networks are not doing good today. So we are hoping all will be well as we continue. God be with us on that. So let me appreciate that all of us are here. I don't know if you can hear me. If someone can just respond and say, we can hear me. So yeah, I'm seeing that some people want to join. I guess we can support one another. I'm looking at okay, so last week we had a great last session in the past Adawit. We had a great session and we were enjoying. We were looking at nausea and vomiting. So we were looking at nausea and vomiting in palliative care, and we noticed that that's one of the symptoms we can reverse or deal with, and we understood that it is very important. It is very important to find the root cause of the nausea and vomiting. And we said that to do that, we can work on the 13 M's that we're looking at. And we have the video in our YouTube channel, ECHO-Eswatini Hospice at Home. And also we have it in our ECHO platform. So what I can also say is that we also had Manzini Government Hospital presenting a very good case that we all learned from it. Yeah. So for now, I don't know if Tandazile, you have something to comment concerning any change or progress that has happened with your previous case, if any, before maybe we can embark on today's presentation. Can I give you the opportunity to say something concerning our last case? If you have anything for the team as a catch-up or as a feedback or any progress made.
Thank you, Chair. Thank you, Chair. On behalf of Tandazile, I think let's proceed. Maybe she'll comment later.
Oh, okay.
For now, yes, please. Thank you.
Thank you. All right. So I would request that we all introduce ourselves on chat. You write your name and the people you are with and then the facility you are from. And then during our sessions, whenever you have to say something, you will introduce yourself and say that. So may I go straight to our presentation now. So today we will be looking at what we call anorexia and the Cachexia. So that's what we are going to do today. So can I put a slide here so that we can see it? So I'm hoping we'll have an exciting one even today. It's a little bit longer presentation, but what I'm going to do is that I will try by all means to make it short as possible as we can, with the hope that you will have access to the platform and be able to then read on the presentation for yourselves. Okay, can you all see my slide? Can you see my presentation slide on your sides?
Yes, sir.
Yes.
Okay, thank you. So we're looking at anorexia and cachexia in palliative care. This is one of the challenging symptoms that normally we face. I will also mention that in my experience in home-based, I've noticed that this one is most common when the patients are approaching the end. So it's true, especially Cachexia is more experienced towards the end of life. Anorexia is in between. So we'll look at anorexia and then Cachexia, then a round of the pathophysiology, and then we'll look at the assessment and management. So I'll just go straight. So anorexia is the common. I hope everyone in this room, if not more than 70% of us has experienced anorexia in our life, which is the loss of appetite. One of the things we might go through in life related to different circumstances, you know. Some gentlemen will be dumped by their girlfriends, so you'll find that they're not eating. Even you take them to Mtunyelena, they will not eat. So they will experience anorexia. So it's one of the common problems that we might face in our lives. So then, but this anorexia becomes pathologic then when then it leads to cachexia. So cachexia, we say it's the multifactorial wasting syndrome. So I don't know if anyone can say, when do we say that now this person is now cachexia or cachesic or has developed cachexia? Anyone who can guess, when do we say, oh, now there's cachexia here? You can just put on chat or just say it. When do we say? What normally do we come up with and say this now, this patient is in cachexia? Because there's anorexia, and now we are saying that my patient now has cachexia. When do we say that? Anyone who can share? Just I'm watching, or you can just unmute and then share. Anyone who thinks or who can think, even not raising your hand, just shooting, or you can put it on chat if you have. When do we say now there's cachexia here, there's multifactorial wasting syndrome? What normally do we see? What normally do we see? Okay, I'm looking and I'm watching on my chart if there is anything coming. Anyone who wants to share something? Okay. Someone is saying that mostly they lose much fat and muscle tone. Yes, yes, yes. I can see that muscle and fat. So they lose much fat and there is muscle tone loss. Anyone else who wants to say something? When do we say now there's cachexia here? Okay. Yes, you can share Lumpumelelo. I cannot see hands here. Yes, you can share and unmute and then share.
Okay, good afternoon, everyone.
Yeah. Afternoon.
Am I, can you hear me?
Yes, yes, we can hear you.
Okay. So just to share with you with the cachexia, like we are saying, it's a multifactorial, like wasting syndrome. So multifactorial meaning it's caused by a lot of factors. So usually it would include maybe like we have digestive factors, we have factors due to the tumor, or other factors like hormonal factors. So this one with cachexia is characterized by the loss of muscle, whereas in anorexia we only have the loss of the weight, but this one there'll be much wasting. And with cachexia, you have, even if you eat the food, even if you can be giving the patient the food, there's nothing that will happen. So it has stages also as well. So sometimes the first stage can be like maybe loss of less than 5%. Now, when the patient has the cachexia, there is loss of more than 5%. And then we have different types of them. Like if the patient now has a cachexia due to cancer now, so that one is irreversible. Whether you are feeding the patient or what, it cannot be reversed at all. Thank you.
Thank you. Thank you so much, Nampumelelo, for sharing that. I have something to sort here. It is giving me some little bit of trouble. I will come back. I don't want it to be like this. Pardon me a moment. Yes, this is what I'm looking for now. Yes, so as Mpumelelo said it, one of the symptoms of cachexia is weight loss, more than 5% of the body mass. And then, but if the patient is already having a BMI of less than 20, less than 20, with a BMI less than 20, we are saying that then we will say my patient has now become cachexia when my patient is presenting with a 2% decrease in the body mass. Another thing that we need to understand when it comes to cachexia is when there is a loss of muscle. The fat is there, but it's not the clear cut. So when you differentiate it with anorexia, for when we say now it's cachexia, it has to happen with loss of muscle. Okay, so that's when you will differentiate it. That no, once there is a muscle tone or muscle loss, then we are saying our patient. So there are 3 phases that a patient moves when they are undergoing this condition. They first go for pre-cachexia where they have a weight loss less than 5% with anorexia and then some metabolic changes. But then they move to cachexia now when it's more than 5%. And then when it's a BMI less than 20, then it will be more than 2%. And normally there's often reduced food intake and sometimes with systemic inflammation. So we are seeing them now experiencing some systemic inflammation. And then we move towards to then the refractory cachexia, which is most of the time more prominent when they are approaching the end of their lives. So then at this point in time, you'll find that even if you try to do anything with them, they will not recover. And sometimes you find that within 3 months or very few months, depending on the condition they are having, the trajectory will quickly go down and you will have that patient RIP or they've died. So they move to these phases. So as they move, when they are monitoring the weight of the patient, will they present into your facility? It is very important to get their weight because it also tells you if then they gonna become cachexia very soon. Okay. So then we have differences that we have here to separate cachexia and anorexia. So there are only few that I have that comes classical when we talk about this. The first one that is so classical is this one. Our patients normally, when they are cachexia, you find that their metabolism is increased. So their metabolization goes up, but then their skeletal muscle go down, you see. So they are burning a lot of everything that they have in their body, trying to compensate their energy and stuff. But you'll find that when it comes to muscles, it's going down. And then the other difference that we need to find is that, which is so important when you understand that now it's cachexia and anorexia, is this difference. That once it is anorexia, once you feed that patient with anorexia, you will find that the feeding will have an impact on the patient. But then feeding a cachexia patient is like wasting the resources that you have and inflicting harm on the patient. I usually make jokes that are sometimes real, saying that if you are going to feed this patient who is cachexia at end of life here, this patient will never forgive you in life. Unfortunately, you will never get the opportunity to come and say, I apologize for what I did. But you will find that it's not working for them. So this is very important to note while we are going through this presentation, that when you have anorexia, you are losing the fats, only not the muscles. But then feeding you when you have anorexia is going to make a good impact. But then if it's cachexia, metabolism is high and the skeletal muscle lost. Okay. So it is very important to understand that cachexia come in different forms, and the more severe sometimes it varies with the site of where normally the cancer is located. So the more the cancer is located on the journey of metabolism and eating and stuff, it becomes more challenging, especially if it's on the upper gut or it's in the pancreas or it's the say lung. And sometimes the incidence of anorexia and cachexia increase with the stage and with the children and with the elderly people. So it becomes more severe and it's more common. You know, when people becomes very old, it's common if you have an elderly patient who's sick, you will find them not eating. And they will say that, no, it's because when sometimes they are going through a lot, and it's more severe with these types of children and elderly patients. Okay, so the impact of anorexia and cachexia can be that it reduces physical function. Okay, the fact that it affects your muscle. And remember, with this patient of palliative care, we need their muscles a lot to keep them going. We want them to exercise, we want them to be ambulatory, moving up and down, you know. We need them to come to hospital, we need them to do many things, and they need the muscles. So once they go through these conditions, you find that then their physical function goes down, and sometimes their tolerance to anti-cancer therapy, chemo, and other treatment therapies, their tolerance goes down. And also it increased their susceptibility to infection. So you'll find that now they become more infected in different conditions. Their immune system go down. And then again, when they will be admitted, you will find that they will require a length of stay in hospital. And then the fact that they will be admitted in hospital, I'm challenging every one of us to one day sit down with the account office, calculate how much does it cost to admit a cachexia patient in the hospital. And you will see that they stay long without change, because now we know even you feed them in either direction, they will never improve. And then they will take more money because there's drugs, there's staff, there's everything. So they require a lot of funds when they are admitted. Even if they are not admitted, let's say, maybe they are at home, it affects the caregivers. And in our context as African people, and especially in Swaziland, we know that most of the caregivers are women. So there's a lot of impact on the women and who are caregivers on these patients. and takes them financially, emotionally, socially, and spiritually. It drains them, the family members, they go a lot. And then when you look at the quality of life, continually decline as they are going through this anorexia and cachexia. And lastly, maybe, but not least, it results to poor prognosis and finally increase of mortality rate. You will find that this patient will not recover, will miss them, or will lose them due to different conditions, including cancer, whatever they have. So it increases the poor prognosis rate, and then also lead to poor or increased mortality rate. So these are the impact of these symptoms, and they are most common when our patients are approaching the end. So the part of physiology, I will not dwell much in this, but let's take an example of cancer, because this is where most these symptoms are experienced. But we also have the other conditions that are under palliative care, where also they go through these situations. Your patient will have cancer, a tumor, and then it affects the immune system. And then what will happen, the immune system will produce cytokines, and the tumor will produce other hormones that will lead to metabolic abnormalities. Once the metabolic abnormalities happens, and then there's a disintegration of the fats, and then there's anorexia, there's also disintegration of the protein. So there's proteolysis and lipolysis. And all these three products will result to what we call cachexia. So comes to cancer, then the problem with the immune system, and then the tumor, the immune system will create or will produce the cytokines, then metabolic abnormalities, and then it results to anorexia, lipolysis, and protein lysis, and then that one will lead to cachexia. So this one, we are saying that there is what we call a chronic inflammation with this condition. So the cachexia comes with chronic inflammation. So what then happens is metabolic changes happens. Once there's a metabolic changes, they lead to lipotic and prolific substances that are produced, and then the body will release, there will be hormonal changes that change in the level of catabolic and anabolic in the hormones. And then that one also goes down and lead to the role of the neurotransmitters. There's an increased lipolytic effect on the catecholamines, and there's a natriuretic peptide, and then there's psychotic impact on the hypothalamus. So there's then serotonin and dopamine release there. Then this patient will end up looking at this picture when there's a disease, and then we have the host, which is the patient. So on the other side, there's the cancer. We'll make that example with that palliative care condition. And then the other side, there's the patient itself. So the disease itself will have this disease-specific products that will lead to proteolysis inducing beta lipid mobilization, mobilizing factor. There's pro-inflammatory cytotics. On the other side of the on the other side of the patient is endocrine abnormalities, uric sympathetic activation. All these things, they result to decrease in muscle myosin, fat lipogenesis, decrease and increase lipolysis, and increase proteolysis. So all these things happens in the body when this patient is going through these conditions. So when we look at the fluid metabolism, then what happens in the fluids, or in the blood, I would say so, or in the composition of the fluid. So there's the body weight that we know there's 40% solid and 60% of fluids. And then there's intracellular in the fluids, which is state of the whole 2/3 of the fluids. And then 1/3 goes to the extracellular. And then from the extracellular, we have the 75% interstitial fluids and the plasma, which is just normal blood distribution in our bodies. But then when we look at the homeostasis mediated by the homeostasis of the fluid is mediated by one hydrostatic pressure, normal the cardiac output, and then the oncotic pressure, which is very critical when it comes to protein maintenance in the blood, especially the protein albumin. So, and that one is the most important protein when it comes to cachexia. So the colon-ocotic pressure also is there. And then also the crustal osmotic pressure, which deals with the electrolytes, glucose and urea. So when you look at this pressure in the blood, and then that's how the pressure is maintained. So then now fluids are balanced in our body and they're circulating evenly very well. But then the challenge happens when cachexia comes. Then when cachexia comes, what will happen? The patient will significantly lose albumin. The albumin, when you're taking your labs, you'll find it very low. Sometimes you'll find it less than 2.5 milligrams per deciliter. And around that one, what will then happen is the oncotic pressure, because of the decrease of the albumin, will go down. Once that one goes down, the intravascular volume will go down, because then that water will go straight to the interstitial places. So for this reason, the water link will sort down and then go to the interstitial spaces as it is. And then this one leads to what you call peripheral edema. The time most patient who has cachexia, you will find the peripheral edema and the swelling ankles, you know. And then once these fluids are escaping to the interstitial spaces, they increase the risk of pulmonary edema and sometimes or increase the risk of dyspnea. That's why it's a point in our presentation, we'll then look around the dyspnea. So one of the causes of dyspnea will be cachexia. Once our patient goes to dyspnea, now we are required to bring more supplies. Maybe we will need more morphine to control that. We will need oxygen. You know now, our patient will go a lot, but this is what happens with the fluids. So if you look at it in terms of the blood, this is the normal against the abnormal. If you look at the abnormal, albumin in the blood will go down, and then what you're going to see, the muscle will be lost. You see that 40% there. The patient had enough fluids in the muscles, but now the solids are down. The patient will be losing the muscle less than 40%, while fluids will go up more than 60%. And then what we will see intercellular fluids going down, but extracellular fluids going up, meaning interstitial fluid will go more than the 75, while the plasma will go down. So it leads to totally abnormal situation. And when I look at this patient losing, dehydrated, dry mouth and all those stuff, you might be even tempted to bring IVs and say you are dehydrating. So the secondary causes of anorexia and cachexia, one, it impaired oral intake. Okay, so stomatitis, despite a change in taste and smell, will lead to cachexia. You know, there are many situations the patient they will go through. Sometimes they have cancer that's around the mouth and the oropharyngeal, so they will have difficulty to eat. And sometimes the location of the cancer is just on the route where the patient will be eating, and by not taking any food, and then our patient will go straight to anorexia and cachexia. Sometimes having chronic nausea. Last week, we were talking about, last session, we talked about nausea and vomiting. And we said that there's sometimes continuous intermittent nausea, vomiting. You remember that breakthrough nausea and vomiting. So when our patients are going through this, then you have what we call autonomic failure or with brain metastasis. There are many causes of chronic. We remember sometimes they are taking some chemo or treatment which is inducing them into nausea. Sometimes that is intermittent, or sometimes that is breakthrough. So our patient will end up not eating. There is no way you can be throwing out your mouth and taking in food. We know that. There is no way. Also, another thing, maybe our patients have malabsorption disorders. Another culprit that we normally have is constipation, which also leads to what? Nausea and vomiting. That's why it's very important that we screen our patients for constipation, because constipation, I don't want to say the mother of some of the problems our patients go through. And sometimes the last time when we were talking about nausea and vomiting, we talked about it also in constipation, we have what we call bowel obstruction. So sometimes they have bowel obstruction with mechanical or stuff. And then also we have what we call more severe symptoms of dyspnea. When our patients, currently what we are seeing as hospice, for most of the patients who have survived COVID, yet they have lung conditions that were hidden. Those lung conditions have come. Some have lung failure, you see. Some have developed lung collapse, whatever they call. They are on oxygen. So they have difficulty in eating, most of them. It's very hard to eat when you cannot even take a small number of egg. So they are there. We are expecting them and we're watching them close because one of the severe symptoms will lead to cachexia, so it's dyspnea. And then they have depression, we'll see it later, and then they have delirium. Another problem that we have, that we treated in our last module, which is pain. Once our patients are going severe pain, they will not eat. Sometimes the patient, you don't need to give them Panad or what. You don't need to give them multivitamin or a lot of things to stimulate their appetite. You just need to control the level of their pain, and then you will see them going back to eating. Okay. I've seen that once a patient has pain, especially when it's around the GI system, food will never be taken by that patient. Okay, then what happens when we are assessing for Cachexia? Now we have seen all this. The first thing we need to do is to get the appetite and weight loss history. You need to know how has this patient been doing in normal. That's why it's very important that when we have opportunities in our different, but let's take the weight as possible as we can so that we can know how is our patient going, so that you can trace if your patient is still at pre-Cachexia or is it Cachexia now or is already refractory, because the weight will tell you that your patient is going down. And then identify reversible causes. You know, all the previous ones, we see those reversible causes that we can reverse. So one of the things we did when we were starting this module, we said that one of the principles of symptom management in palliative care is to reverse the reversible. And the second one is to identify the cause of the problem before addressing the problem. Because addressing the fruits will never help you address the problem. So it's very important to identify in Cachexia and anorexia, very important to identify the reversible causes, because those are the ones we're going to deal with. And then you also do what the physical signs of wasting, we can do our work and stuff, you know. And then we have the biochemical markers for us, team members who are from facilities like Monet, they have a laboratory around, RFM, they have a laboratory, these mother facilities. So also albumin and the C-reactive the proteins, they also help. I don't know if they do the CRP, the counterpart. Any of those labor, but albumin should be there to ensure you check if my patient protein in the vascular is doing well. And then also sometimes the radiographic studies are indicated, but also if it's gonna be done, then the X-ray and stuff, if it's gonna be done, it must be weighed between benefit and the risk or the effects of it. Is it going to benefit my patient doing this in-depth diagnostic or examination? So the ones are very important when we're doing this. So just to list reversible causes of waste, we have psychological factors, which one of them is depression. You know, we need to deal with that. Mucoitis, nausea and vomiting, malabsorption, constipation, early satiety, pain, and so they have many social economic. You know, if you are a healthcare worker in Swaziland and you know exactly how does it feel to suffer socio-economic. The day a commercial take all your money from the bank, you don't eat. You just go straight to anorexia. You know, socio-economic, just to be divorced, even divorce is too much. Just to be told by your boyfriend or girlfriend, it is over. You just go straight to anorexia. And if not well managed, it can go deeper and complicate, become pathological and bring Cachexia. So there's a lot that our patients go through. Some of them are comorbid conditions that will lead them to that. So it's better to manage those reversible causes. So relatives, I have this statement. So I don't know if you have heard that. A relative will come to you, especially for you guys who are in the facilities. But I've also seen this here at Hospice, patient presenting in our OPD with this request. Dogotela, I've get the privilege to be called a doctor even in the community. You know, she's not eating. She's losing weight. Isn't there anything you can do? Have you ever heard of this? Or have any relative approached you with this? Or unless have we ever made this complaint to doctors? The patient is not eating, one. And number two, my patient is losing a lot of weight. And on court, probably because he's not taking any food. Is there anything we can do? What can we do? Is there anything we can do for this one? I'm watching, you can share on chat. If a patient presents like this, normally for this patient we have Cachexia and anorexia. It's not the patient who presents with this. The people who present this complaint are the caregivers or the healthcare professionals, right? I'm grateful here we have, I don't want to put her on spot, but I will put her down. We have Nompumelelo Dlamini, we know, now she's a qualified oncologist, nurse, oncology nurse, yeah. So I know she has met this, if not in a test, in real life, in the classroom. So they presented this in Monen, they come, and say, next Tandazile, you know, Gogo has not been eating since 2 months back, since the last dose of chemo. And now we are seeing that he's losing weight. Is there anything we can do? Is there anything we can do? What can we do? Is there anything that can be done? Huh? Anyone wants to shoot him for this one? Don't even add words on this scenario. Just look at this scenario and respond. What can we do? Is there anything we can do? What can be your decision? Anyone who wants to share? Anyone who wants to share? I'm checking. A patient present in your facility and say, nurse or doctor, my mother or my sister is losing weight and not eating. Is that what can we do? Hello? Is there anything you can do? Okay, it's so strange. So most of the time, in this case I've presented you, it's an ambiguous case. There are more factors that need to be considered to reach to the decision, right? Sometimes there's something we can do, sometimes we cannot do anything in terms of reversing the situation, but there is something we can do when a patient presents with anorexia and cachexia. There is something we can do. We cannot say that there is nothing we can do, you have cachexia. No, there is something, but then the factors that we need to consider to direct what intervention we can do. Some we can need feeding, some can need IV, some can need just sips, we can need Vaseline, some we need supportive care. So there are many of things we can do. One, we can treat the comorbid condition. Two, we can reverse the causes. Okay. If ulcerative mucosal bowel obstruction, pain, what could be the cause that makes our patient not to eat and lose weight, right? We can look for favorite foods and nutritional supplement wherever it's applicable. We can also do what we call education, counseling, and support. I will emphasize on the last bulletin. Educating the patient and the family is very important in counseling and support, reassuring the patient that we are going to support the patient through and educating them that Cachexia and feeding, there will be no impact. You know, some of the families, they will even open your mouth forcefully. I like those patients who deliberately close their mouth. They will open the patient mouth forcefully and push the food by force. Let alone we as who are sophisticated, we come with our technology, energy tubes, and force into the patient's nostrils and stuff. You know, that's very painful, but sometimes supporting the patient, educating them so they understand that now maybe feeding also would be not beneficial. So sometimes enteral parenteral feeding does not work. In Cachexia, it doesn't work. Sometimes supplements, you bring your multivitamin, you bring your steroids, you bring your you are bringing everything. What you're going to do, you increase weight by increasing fat mass. What is doing? But the quality of life and survival still goes down. And the muscle tone or mass still goes down because the patient has what? Cachexia. Prescribing multivitamin to a patient with Cachexia is the waste of resources. So you need to know, why am I prescribing this? Is my patient not undergoing Cachexia? How much weight has the patient lost? What's the BMI now? Oh, my patient has lost more than 5% of his weight or her waist. So now he's approaching the end, pre-Cachexia, Cachexia, or preferential. Then you will know the interventions. Okay. So sometimes what are we going to use? There are many things that we normally use in palliative care to manage anorexia. We have growth hormones, androgens, and stuff, but I will just mention the two. One is olanzapine. I don't know if Tandazile presented about this last week, but I'm happy. I think last time, I think you mentioned this, but I will mention it again. Last time when we were doing approach, we said that one of the drugs we use in reversing nausea is this one, olanzapine. Why you might not know that is the anorexia or is the nausea. That's the cause. So then you will prescribe olanzapine or dexamethasone. So for that, they will give a dexamethasone maybe for 3 weeks or so, see if my patient is coming back. The time, these drugs are wonder drugs in palliative care. So these two are the most basic drugs we can use to manage anorexia for these patients with serious illnesses. Okay. And then when it comes to cachexia, I will not mention even one of the drugs, but they are here. But the most important one is to exercise those muscles that we need, right? Because the most important thing we are looking for in this patient, giving multivitamin and stuff, they will not yield that much effect. But exercise, I'm requesting my patient to take some intentional exercise. It's very important when their patient is experiencing anorexia, and it's possible when they can with this condition. It's very important to encourage them to move so that the muscle gets that exercise, you know, because the only thing that builds the muscle very well is exercise. The rest is another story. All right. Another thing that I will mention that I have not put in this presentation, once talked about it, are the dilemmas between artificial hydration and nutrition. I will just say, once my patient is cachexia and is at end of life, let me say it, it's painful, but we need to manage it well as healthcare professionals through education, counseling, and family support. There is no evidence that supports or that says patients who are fed, whether NG2 or what, when they are approaching the end of life and they are experiencing cachexia, they will improve. You will find that our patients are NG2, they are trying to feed the patient who is going. I usually say they will never forgive us anymore. You will find that sometimes they end up developing pressure sores, pneumonia. They get worse because now we've put an NG tube, we have done all those things. Sometimes you will put them into hydration. Instead of this patient who is dehydrated, instead of putting them into IV, it's not going to help them address the cachexia. The best way is to use alternatives. Maybe you use ice, you use Vaseline, mouth care, you know. So we'll see those issues. Those interventions, they are helping in helping this patient cope with this. Then is the issue of education, counseling, and support. But in summary, let's say that studies demonstrate net harm when routine providing better nutrition to the patient with cancer. I've already said that. Evidence also suggests that A decreased tumor response to chemotherapy when patient receives parenteral nutrition. So sometimes there is a decrease. If my patient is on empty tube, evidence is saying, putting my patient into parenteral feeding and then taking to chemo, the response of the effect of the chemo, the patient goes down. There are no approved pharmacological treatments for weight loss associated with cancer cachexia. Kwamanje, who says, but scientists, we are hoping they are doing the best. So currently, there's no approved pharmacological treatment. I cannot say this one is the best. The weight gain associated with the use of menstrual acetate donapinol, dexamethasone is primarily adipose tissue fluid, not skeletal muscle. So we are trying. So it's not really addressing cachexia, actually. So clinicians, we must educate caregivers regarding cachexia. Given the distress it causes when caregivers witness anorexia, waist loss, weakness, and decrease in quality of life. You know, our culture in Eswatini, especially, or in Africa, we believe that we survive by eating. So if my client is no longer taking food, is chaotic, that means I have killed my client or my relative by starving, which is not true. So that's why we are saying education, counseling, and support is very important for patients who has cachexia, because they then go to depression. We don't want them to go there. You know, they go to intense anxieties and complications. So we need to help them cope well with this. So the major thing is to know when to stop and when to continue. Know exactly what to do. So cachexia is one of the distressing symptoms. So we need to educate, counsel, supporting, reassuring. Then our clients will appreciate. How would you feel if you're going to feed your client who is chaotic, only to discover that there was regurgitation and your patient died on spot? How would you feel putting an empty tube, so much expensive, and your patient developed all these complications of pneumonia? Your patient then end up losing freedom to actually have all these irritations, increased production of mucus. You know, there's a lot that comes with these intensive therapies. So let's know exactly what to do. Cachexia happens, and it's one of the distressing symptoms that we normally face in our palliative care. Thank you so much. I think this is the end of my presentation. May I open this opportunity for you to share and comment whatever you may want to share in these few minutes before I request Mr. Pungwayo to share a case that we can also brainstorm on for today. On this topic that we have had, we are faced with cachexia. Most of our patients, the cancer ones, organ failures, frailties, they have stroke, bedridden. You know, they undergo cachexia at some point. And the relatives, they spend a lot of money hiring a taxi or a for hire to take them to hospital. They come to hospital, we take them to bed, but the situation still goes down. Palliative care is all about quality of life, improving comfort. If my patient is going to die, dignified death, that's so precious. How does it feel to see your patient going to heaven or to the ancestors? Clean, nice, comfortable, smiling, pain-free. I think they can even bless us. We will all become managers very soon, promoted, because the patients we've taken care of, they've blessed us. Why? We never subject them into treatment we knew is not gonna work. But we were just doing psychological game with the relatives, using the patients as our specimens. Yet we knew it will not reverse the situation. Can we bring in counseling? Can we bring in education and support? Manage where possible, where we can. All right. Can I give opportunity for colleagues to share? What do you understand? What have you get? We are all sharing. In my presentation, I also shared what I've also seen on the class. Tandazile, I can see your hand on chat. You can share, madam.
Afternoon, team.
Hallelujah.
Thank you. Thank you so much for the presentation, Mr. Mahlangu and team. It's great what you've put in there, and that was quite enlightening. Please correct me if I'm wrong. I don't know whether my memory still serves me well. I may need to consult or check with, is it the guidelines or your training materials, where I think we discussed that cachexia is actually one of emergencies cancer. So I'm like, is that true? Before I continue.
I'm not sure. Palliative emergency, like bleeding, I'm not excited. I haven't seen it as a Cachexia emergency, but let me confirm for you. But I doubt it can be an emergency because normally it happens at the end of life. So even if you can take me to the emergency, there's nothing they will do to reverse it. Especially
I was still trying to check that. It's just that, yeah.
Yeah. But I will confirm before I leave that. But I doubt it. I haven't yet confirmed, but not it under emergencies, because it's always weight loss. Normally due to the underlying condition. Okay.
Okay. Let me check. I'll get back to you before the end of the session.
Thank you. Anyone else? It's not. If the specialist like Dompomela confirming this, then I'm good. Yeah. It mustn't be, because when we are doing trajectory of the disease and plotting the palliative care phases, once my patient is at terminal phase, even not before terminal, once the patient begins to go to deteriorating phase of palliative care, and then they go straight to ECHO-4, one of the things I will predict to happen with my patient is the problem of cachexia and anorexia. So those ones are not emergencies, are expected to show up along the way. So they cannot be emergencies if you're not going back there. Just combining these two evidence that I'm providing. Once your patient moves, when in palliative care, they start from stability, unstable, they go down to terminal until bereavement. So if you can plot the chart against the epoch functionality status, there is a level where you expect certain symptoms of end of life to show up. Cachexia is one of them. So it cannot be an emergency, but it's something we have to prepare the patient psychologically, spiritually, and emotionally to handle it when it comes, because we will never take it back. But when then there's what we call fecal impaction and stuff, those are the emergencies. They need to go to theater and operate and remove those blockages, you know. Those are emergencies, yeah. Bleeding and stuff, I cannot list them, but they are there. Those are emergencies because we can stop them. Yeah, palliative care is limited emergencies. Things we cannot reverse in palliative care, they are not emergencies. It's things we need to manage and help the patient cope with. Okay, thank you, Mpumelelo, for that. Anyone who adds a comment? Bam, 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 bam. All right, I don't see comments coming. I don't know whether it means all things are good. I don't see anyone, my team, I don't see anyone. They asked if Cachexia was asking if Cachexia is a palliative care emergency, and as I say that, no, it's not. We know, you know what, once you have a patient diagnosed with cancer, let me make an example. I have my patient diagnosed with cancer. Every time I'm reassessing my patient, or I have to contact with my patient, when I'm plotting the partial status of my patient is going down, right? when I'm checking the weight of my patient is going down. Once it's more than 5% of the body weight, then I'm diagnosing my patient as Cachexia. 2, I am predicting end of life very soon, because the decline, the rate of the decline is very important for you to tell if my patient is coming up or not. Another demand is when you're looking at the stability of the patient in terms of symptoms, psychosocial issues, and the family and the caregivers. When they have these deteriorating functionality status and deteriorating symptoms and stuff, you begin to predict the symptoms that will come, right? So you can tell once my patient is going down functionally wise, possibility is Cachexia is on the way. Okay. All right. Even our great mother said, indeed, Cachexia is not an emergency. We can prepare for it. Prepare your clients as early as possible. Stage 4 cancer, you know now we are not going back. Just educating them when it comes to eating, find their cultural understanding of how do they treat diet and eating in their culture. What is their take? Spiritual attachment to food, cultural attachment that comes with food. Because some will find that it's a culture at home that we eat together. If you are not eating, it means you are a rebel in this house. So these patients who are undergoing Cachexia will be forced to eat. Some will believe eating, as I've mentioned, is for life. Yet we eat, yes, to be okay in the body, but life is from God. Once I usually joke and say, a Cachexia patient is already eating his meal in the future. So whenever he's eating with the angels, don't disturb with carnal meat and food. Allow them to eat what they are eating. Sometimes they will choose. Before I forget, this is where advanced care planning is very important, Kim. If our patient could make these advanced care directives or advanced care wishes and preferences as early as stable as they are, we will not go into trouble when it comes to feeding with Cachexia. Even those patients who will force them, will be able to manage them. All right. Maybe before I waste the time, may I give Mr. Puma this opportunity to share his case that I think we can also help him manage. Yes. I hope we can all see Mr. Puma's case. He will just share with us and then we can share. If you have a question on this Anorexia Cachexia presentation, you can share here on chat. I will be looking and responding, and other team members will also assist, will respond to it too. So, Mr. Pumayo, you can go ahead.
Good day, ladies and gentlemen. Thank you, Mr. Matanga, for the introduction. As I've been introduced, I'm Pras Pumayo, and I'll be presenting today's case. So our case today is about a patient who is 68 years old, female, diagnosed of breast cancer on stage 3. The main problem or concern I have about this client is that the patient has lost a substantial amount of weight in the past 2 months, which is wasting syndrome. 2 months ago, she weighed 85 kilograms and currently she weighs 55. On holistic assessment, or rather chief complaint, the patient complains of witnessing recurrent episodes of gastric reflux promptly after ingesting solid food for the past 2 months or so. So basically this insinuates that the patient has zero tolerance for solid food and only survives on fluids or rather soft foods. So I would love to get suggestion or recommendation on how one could best take care of this client. Comprehensive assessment of present pain, or rather we'll look at the characteristics of pain. Since I have one encounter with the patient, the quality of pain on assessment was visceral pain, Its location was on the left hypochondral region, which is referred to the back and scapula. Pain intensity on numeric scale is 6. Time or temporal, it is idiopathic. And this is chronic pain. Activity or rather mobility aggravates the pain, and it is relieved by warm compress or relaxing or even tepid sponging with water. She's currently on both non-opioid and weak opioid, which is tramadol and paracetamol. Both these analgesics completely alleviates the pain. On physical assessment, the following were observed. The patient has tremendous weight loss. She is skinny. There is anorexia. She is lethargic. She is anemic. This was seen through poor capillary refill and pale mucous membranes. Psychological aspect assessment. The patient is going through mild depression since she can no longer perform activities of daily living like performing personal hygiene, or grooming, dressing, toileting, ambulating, and eating. On assessment of social aspects, she's a retired teacher. Went as far as tertiary. She is of middle class socioeconomic status. She is married. Lifestyle habits. She occasionally takes sips of wine, which is believed to aid in digestion. There is unknown relevant health condition in the close family members. Other social related information. She has a very supportive family. The patient resides with her nuclear family, which comprises of her husband and 2 kids. On spiritual assessment, the patient derives hope from God, family, and friends. She affiliates to a Nazarene church, which is very supportive, as the congregants often televisit or home visit her at her matrimonial home. Significant surgical or medical history. Although she vaguely remembers the dates, but she did 6 cycles of chemotherapy at some point. Okay, medication. There is no relevant past medication, but rather there is current medication. She's currently on 50 milligrams of tramadol, 500 milligrams of paracetamol, 10 milligrams of isapodil, 20 milligrams of tamoxifen, 25 milligrams of hydrochlorothiazide, and 20 milligrams of nifedipine. Under advanced care planning, okay, nothing much has been done since there is no DNRN in order, no advanced statement of wishes, no healthcare proxy. However, mental capacity was assessed and the patient was found to be stable and well-oriented to place, time, and event. However, she has mild depression. On assessment of vital signs, they were found to be normal with the temperature at 36.4 Celsius, BP 128/64. Then the pulse was 78 beats per minute. Respiration rates were at 16 breaths per minute. Unfortunately, the saturations couldn't be measured due to unavailability of pulse oximetry. The patient is on ECHO-3 functionality stage. On assessment of symptoms like pain, it was found to be moderate. There was no dyspnea, mild anxiety, no agitation, mild depression, severe drowsiness and fatigue. There is moderate nausea and vomiting, moderate anorexia, no constipation, no dry mouth, and overwhelming poor mobility. Okay, unfortunately, there were no focused investigation or other lab results available at the time of assessing the patient. However, the further plan for this patient is, patient was referred patient for medical officer review or rather further investigation. Probably endoscopy may be ideal to rule out gastric or peptic ulcers. Advise the caregiver to feed the patient sparingly, ideally small frequent meals at a time. They were also advised to keep the patient on semi-phallus position after eating, probably to try and prevent the gastric reflux. We also advise them to ensure that the patient sleep on an inclined position, also to avoid gastric reflux. Lastly, we advise the patient against taking of carbonated beverages. So this marks the end of our case presentation. Indeed, it is short, but rather we seek assistance or recommendation on how best we can take care of this patient, as she is now low weight. Thank you very much, ladies and gentlemen, for lending me your ears.
Thank you, Mr. Pumayo. I hope colleagues will have hit Mr. Pumayo's case. Yeah, what a case to think about. Just to summarize, the patient is has a cancer stage 3, and the major concern of Mr. Pumayo is requesting and presented is that this patient has lost substantial weight, which is equivalent to 35.3% of his baseline weight, from 85 to 55 kg. So he said that now the patient looks bony, and this patient has a history of taking chemo, and now he is on ECHO-3, meaning he's only able to do things that, but he's always confined to bed or a chair. He cannot move around, do things. And this patient has a good supportive system. When he said that one of the complaints the patient has is gastric reflux whenever he has taken solid food since the past month. So in short, the patient is not taking food. So she's only surviving with soft food or liquids to make it, because once you take anything solid, a reflux happens. So that's what he has shared. And then he has a well-controlled pain using step 1 and 2 drugs. And then, yeah, let me end there and say, team, I hope we've got the case. How best we can manage this person? What do we think is happening with this patient? We can share and then advise Mr. Pumayo. I have 10 minutes for us to discuss. Anyone who wants to share something or ask Mr. Pumayo or comment on what Mr. Pumayo can do. This is a cancer patient, stage 3, staying with his children and husband in their home, and then is a retired teacher, and then diagnosed with this condition. Now, I can say he is experiencing cachexia. He's going down. In 2 months' time, he has lost 20 kg. In 2 months, 60 days, 20 kg gone. And Mr. Pua is saying the patient also is looking bony now. So you know an 80 kg person, how big is his? And then if you've lost 20 from that, you can tell how much that person looks like now. And then the patient is, I'm sure, has depression, as Mr. Pong said, for many reasons. One of it is, every time I take the food, it comes up as a reflux. How can we help him? I'm sure he's at home. So I think that's one of the reasons some of the investigations are not here, like abdomen, oxygen saturation is not it because, you know, currently we don't have it here. What can we help? What can Mr. Puma do to help this family and this patient do better? Can we share? ECHO-3, bed confined, okay? Has it been explored what could be causing the depression because on the support part, she seems to be okay. That's Nongumelo is asking if it has been explored to see if what could be. Yes, stage 3 cancer, breast cancer, right? Breast cancer stage 3 with history of completed chemotherapy 6 cycles. Now bedridden at home with Cachexia. Every time taking food, gastric reflux. Pain control, but bedridden, body weight down, fatigue, all those things are with the patient. Cannot move a lot, quickly gets tired. So he was asking if it has been explored, what could be the cause of the depression? One normal the patient is saying that's what we don't ask. If has it been explored, what could be the leading cause of support your food?
Okay, thank you, Honorable Melelo, for the question. From what the client verbalized, she's mainly bothered by the fact that she can no longer perform a number of activities of daily living, like doing self-care, including bathing herself, feeding herself, and all the like. So I picked up that mainly the depression is caused by the fact that she is now bed confined or bed bound.
Dependence. We call it in palliative care. Is it family or social role? I can see Mhlanga was here. I don't know if it's still. We call it loss of social role or family role. You know, women in Swaziland, we know. If I'm the wife, I'm the manager of the house. I do the things, I cook, I do the things. But being dependent on my husband and children as a wife becomes a problem. Maybe loss of functional status will lead to depression. Maybe. I don't know if Mhlanga is Nongumelo Dlamini. I have a lot of Nongumelos today. Nongumelo Dlamini is answered. Yes, Kababo. You are welcome. Happy to see you. You can talk.
Thank you very much, Mahlangu. Sanibonani nonke. Siyaphila. I got the question, and thank you very much, Nompumelelo Dlamini, for asking that. And thank you, Mahlangu, for the response. It is most of the time, us women, we are so much. We feel we have lost a lot of things when diagnosed, just being diagnosed with a terminal illness. It causes us to lose a lot of things, which may result in us being depressed one of the things that the patient you talked about is the fact that she's a retired teacher. It is a cause for depression too. The other things are the diagnosis and the loss of body weight. Most of the things are causing a lot of depression to the woman. And the other thing is, I don't know how to put this. When we talk of death, dying, grief, and bereavement, it is not only loss of life or other things. The fact that the woman has lost her role as a woman, one at home and even in the community. That one used to be standing in front of many people and she's the one talking. Now she has lost all the other things. And maybe that is why she's diagnosed with double cachexia and stuff. Besides the cancer, you said she has cancer most.
Yes.
You said the other, yeah, besides the cancer, because some of the things are causing one to lose weight, to lose appetite, which is most of the things that results to one losing weight. The first thing is that I lose appetite. I just don't feel like eating because I don't feel like living anymore. I've lost the reason why I should live, because I'm no longer a teacher. I'm no longer a wife, even in this house. I used to be the one taking care of other people and other things in the home. Just like Mahlangu has said, it is causing a lot of depression, which is most of the time ignored when we are taking care of these patients. We leave out both psychologists and a psychiatrist. Yeah, I think let me end there for now. Thank you.
Thank you, Sana. Yeah. There is our patient, 60-year-old, 68 years old, 8 years post-pension, diagnosed with cancer, stage 3, finished chemo, now dependent, bedridden, unable to feed, unable to leave the bed to the toilet, unable to wash myself, taken care of by my old boyfriend, the husband, 68-year-old woman. Definitely in our culture, the man is older than that. How best Mr. Pumai can help this one? Can we share what Mr. Pumai can do? And now, facility going down, Cachexia taking up. What can be done now? What can be done? Mhlanga, I see your end up or still up.
Thank you, Mahlangu. I'm sorry I joined very late. I was trying to update this thing, so I joined later. I didn't get the social history for the patient, but I think we can move around her close relative. Who else is a female amongst her family members, and who else is much closer to her concerning age? Because attending to her as a sick woman by a man, it is also a frustration on its own. Maybe if you can look around her family members, for someone who is female, someone she can easily relate to, because it is very difficult for a woman to tell a man of her sickness. Yeah, like Mahlangu has said, that culturally, even most as Africans, we normally think that nursing or taking care of people or sick people is the duty of a female or of a woman. So for a woman to be sick and to be taken care of by a man, it is, I won't allow it for a man to feed me, for a man to do, yeah, maybe we can start by looking around for someone who is female. And then we can sit down, then start from there and go forward. Thank you.
Thank you, Kabamo. Kabamo is suggesting that the patient should be explored on caregiving side. Maybe she has a challenge. If there's the challenge, an alternative way should be then made, because Nompumelelo appreciated that indeed there could be anticipatory grief due to the prognosis. And then that would mean we need to explore the patient's preparedness for the end. One of the symptoms that will tell you that death is not far away is decline in functionality status, right? When my patient will move from ECHO 2 to ECHO 3, or using the EOSCI scale, my patient moves from 60 to around 30% of functionality. That is an indication, one time from now, I might lose this patient. But the question is, how ready is the patient? What is the patient? What is the understanding of the patient of what is happening? Because that's what you will get, that the patient is worried about death. Maybe he's not worried about death, he's worried about Mukulu, where will I leave my daddy? You see, so we need to get that issues of anti-capital grief. So discussing those issues can also help. And also channeling the patient to what we call motivational interview. Looking at helping the patient to brainstorm on the good things he has achieved in life. You know, it helps the patient to pick up herself and say, you know what, I'm a great woman. Regardless of what way I am now, look, I've done it. Looking at the age of the woman, we are saying in what this, is it sigma fruit or what? I've missed this. Whereby now there's an issue of appreciating what you've done and regret. Are you proud of what you have done in life, or you are regretting your achievement? Post 50, you become in that stage. And for every stage last, where we are saying now you are reflecting on the good, what you've done, and we are building on what that. And let me go to my comment. Then I'm closing.
Thank you, Tim.
Yes, ma'am.
Can I just contribute a bit on this patient being cared for by her husband? Both options and both opinions are correct. I just want to add what I've seen. You know, caring for your loved one also contributes to the health of your grief and bereavement. So I think what Magemhlanga is saying is quite good, that we get a female person to be with the family and support the husband in the caring, because it satisfies him to care for the wife, so that when time comes for her to leave, now he will say, I did my best. I think all he needs is the support, maybe now from a female carer who will be with them as a family. Otherwise, we do need to support the males, to support their loved one, because it is part of their therapy after the partner has departed. Ngiyabonga.
Thank you, Mama. Including bringing the grandsons, allowing them to, because 68, maybe their grandsons already, allowing them closer, meeting the children, family meeting, discussing the way forward, I think also can support here, preparing the family for the worst that might come, and then also preparing them to come and support, so they understand why it's important to support this patient. I think education, counseling, and support will lead us through here. And I will also add that let's continue to encourage the patient to continue taking the fluids. And then if he's worried that he's continuing to lose the weight, educate about Cachexia, and then they understand, even the family, educate them that. If then the patient is still open, I will encourage also the discussion about the future. Should it happen that you are no longer able to take any fluid or any food by your mouth, how best we can support you, so the patient can decide, even including if patient is still well taken and also psychologically stable, well, even reaching the issue of discussing how the end she perceives it to be, so that we can help them choose what they like and what they don't like, So that one will emotionally heal the husband and the children. Because what I see here, the old man is still here, but the children might be older. So there might be some conflict when the woman is out. Yet, as health clinicians, we have already seen that the patient is going down. The indicators are showing that our client is going. Thank you so much, colleagues. I don't know if I'm leaving someone behind, but I want to say thank you so much for attending this session. Yes, is anyone saying something?
You know, but what I wanted to say was, you know, at the end, Sibone course of Steve Ashumayela.
Is this? Hello.
I'm not going to say he's not.
Who is
but in Swaziland, the problem that I see is.
Yay! Who is that one? Okay. Thank you so much, colleagues. Maybe before you leave, please click this link and share your feedback with us. Our next session will be on the 21st of February. We will be looking at mouth care and xerostomia management in people with serious illnesses. So we'll be looking at mouth care and management of xerostomia, which is dry mouth. Let's come and meet on the 21st of February. Thank you so much, colleagues. May we wish you all the best as you continue to do the great work you are doing. Partnership, teamwork. We shall take care of one another so we can give the clients the best we can. Finally, the souls, we've ushered them into good life, some into death, some into recovery. Long live, and they shall bless the Lord, and we shall receive blessings indeed for what we have done for them. If we do it right once, they will never forget us. Even in shopping, the relatives will remember us. Have a great day, colleagues. May you enjoy the rest of your day. Thank you.
Bye.
Bye. Bye-bye, team. Bye-bye. 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 Bye-bye.